My name is Lise, and I am one of the palliative care doctors here at Sunnybrook. You may not have seen me around very much recently because I'm currently on maternity leave, but will be returning in January. And so over the next hour, I'd like to share with you some work that our team has been engaged in over the past year, in particular, this quality improvement project entitled Keeping Palliative Care Out of the Emergency Department. So really in terms of objectives for today, I really was just hoping to use the time to describe the recent QI initiative that our team has been engaged in. It occurred between August of 2020 and May of 2021 and was aimed at reducing emergency department visits for the oncology patients coming to our palliative care clinic. The other objective really is to discuss with you potential next steps moving forward from this. I have no conflict of interest to declare. So to start with some background, it has been well established that patients nearing the end of life and requiring palliative care are high users of the Ontario healthcare system. There's data showing that over 50% of patients requiring palliative care near the end of life have unplanned visits to the emergency department. And I'm likely preaching to the converted, but ED visits near the end of life are frustrating. They're frustrating to patients and families, and they're associated with increased physical distress, decreased overall satisfaction with care, an increased likelihood of complicated grief and mental health concerns amongst the surviving family members, as well as an increased likelihood of acute care admissions and acute care deaths, which I'm sure many of us have seen. So much so that it's actually considered an indicator for poor quality end-of-life care. So knowing this, how are we doing locally at the Cancer Center? Looking back at data for the past about 2 years for patients attending our palliative care clinic, every month, fairly consistently, an average of about 17.5% of our patients come to the Sunnybrook Emerge. And of these visits, approximately 50% result in either a direct discharge home from the Emerge or an admission of less than or equal to 48 hours. And this suggests to us that at least a portion of these visits are likely avoidable. And I'd like to point out at this point that there currently remains no widely accepted, validated definition for what constitutes an avoidable emergency department visits for a patient at the end of life requiring palliative care. And as you can imagine, that definition is likely quite complex and nuanced. Nevertheless, knowing this, our team set out on a project with an aim to decrease the monthly ED visit rates for the oncology outpatients of our palliative care clinic. And the specific aim is to attain a 20% relative decrease. So in absolute numbers, having that percentage go down from 17.5% down to 14% over the course of a year. We started off with doing some system diagnostics to better understand why exactly are our patients coming to the Emerge. And we did this in 3 major steps. The first step was a brainstorm. It was interdisciplinary in nature, involving palliative care, oncology, the Emerge, as well as patients. And it had representation from multiple professions, including physicians, nurses, social workers, as well as care coordinators. And together we brainstormed all the potential and likely reasons why our patients come to our Emerge. This fishbone diagram, as you can see, is the result of that brainstorming session with really all of the potential reasons grouped under the main headings of the fish fins. We then looked at each one of these reasons, or thought about each one of these reasons in more depth to try to come up with which ones are the most relevant as well as modifiable reasons we can think about and tackle that affects our outcome. And the result of that are shown here. Outlined in red are the reasons that the healthcare providers thought were most relevant and contributing. And these include having a language barrier and not being able to access care properly that way, physician coverage while on call, as well as environmental and social issues with regards to living alone and having poor social and home care supports. Patients, when asked, thought that too many contact cards and being confused as to who to call after hours was a main contributor to the problem. And both patients and providers felt that the telephone triage system was contributing, as well as having an acute medical change and not really having anywhere else to go was a major contributor to this issue. So knowing this, we did two other steps. We engaged in a chart review and reviewed about 80 charts over the course of a year, looking specifically at the charts of the patients who came to the eMERGE and were directly discharged home or admitted for less than or equal to 48 hours. We looked at a number of parameters, including reason for ED visit, reason for admission if they were admitted, what was done during the visit, as well as length of stay if they were admitted, and disposition. We also engaged in a few patient interviews to really understand from their perspective, what is it that brings them to the eMERGE? So based on those two steps, these are some of our findings. From the chart review, we found that between 40 and 42% of the visits actually occurred outside of regular business hours or on a weekend. About 71% had a non-emergent investigation or procedure done. About 43% of those visits were from people who lived alone or had poor family supports, and about 18% had a documented language barrier. In terms of some of the themes from the patient interviews, we had three major themes come up. The first was the lack of outpatient semi-urgent assessment options, the lack of after-hours calling clarity for patients, as well as the idea of caregiver burnout and having unmet practical needs being a driving force to come to the eMERGE. So from all of those steps, we've distilled them down to about 6 primary root causes to our problem. And they include lack of outpatient semi-urgent assessment options, the lack of after-hours calling clarity for patients, inadequate telephone assessments, having no routine screening for caregiver burnout and unmet practical needs at our clinic, the lack of seamlessness with home care correspondence, as well as communication problems due to language barriers. From that, we've devised a few interventions that we implemented throughout this QI project. The first was to simplify and redesign our clinic contact pamphlet. So for those of you who have seen our old pamphlet, it was a 6-pane pamphlet with lots of writing. It has now been distilled down to a single contact card with the key phone numbers squared and outlined. We created a LIN resource binder to facilitate during our office hours and after office hours connection and communication with LIN resources. And we also implemented a systematic caregiver burnout screening at our clinic. We also tried to increase video virtual visits for both the physicians and the nurses. During this process, we kept track of a number of measures, and these include the percentage of palliative care clinic patients that came to the ED monthly, the percentage ED visits which resulted in admission of less than or equal to 48 hours, and these include patients who are directly discharged from the emergency department, as well as a percentage of ED visits occurring after hours and on weekends. So what were our results? So this graph depicts the percentage of clinic patients that came to our eMERGE on a monthly basis over time. And it depicts the percentage from January of 2019 all the way until April of 2021. And as you can see, and this turquoise line represents the average. And as you can see, before the study period, the average percentage of patients coming to our eMERGE was about 17.5%. After the various interventions have been implemented, that number appears to have dropped down to about 13.4%. And when tested, this change was found to be statistically significant. We then looked at the percentage of these visits that resulted in either a direct discharge home or an admission of less than or equal to 48 hours. And that, interestingly, did not change and remained at about 50%. looking at the percentage of visits that occurred after hours, so before 8:30 in the morning and after 5 p.m., that percentage also didn't change and was about 42%. What was interesting to note was that after our intervention started, the variability around this average amount, this mean, was much less compared to before the study. It's hard to interpret what that means, but it was something interesting that we noted. And finally, the percentage of ED visits occurring on a weekend was found to have decreased after the implementation of our interventions, and it went down from about 41% down to about 34%. And when tested, this change in percentage was also found to be statistically significant. So really, in summary, we found that the overall ED visit rate did go down in a statistically significant way from 17.5% down to 13.5%. And this was associated with a small but significant decrease in weekend visits. There was no change in the percentage of ED visits that resulted in an acute care admission of less than or equal to 48 hours. And there was also no change in the percentage of visits that occurred after hours. What does this all mean? It's hard to say for sure, but we are hopeful that we did see a decrease in the overall ED visit rates, as well as a decrease in the weekend visit rates. And this, to us, suggests that some of our efforts and interventions aimed at improving after-hours access to care are working. And these namely are the new clinic contact card, as well as the Lynn resource binder. And we do have some anecdotal evidence, both from patients as well as healthcare team members who have found both of those things to be helpful, and who have found those things to have helped with communication and care coordination outside of regular hours. We do need further time to better fine-tune and evaluate the impact of the caregiver burnout screening that was implemented in the clinic, as well as the increase in the attempted increase in MD video visits. And that was because we unfortunately did not get great uptake in those interventions. So we'll need some more time to further look at that. But despite what we have seen, what we do see, so to speak, should I say, there was no change in the ED visits resulting in either a direct discharge home or an admission of less than or equal to 48 hours. And there was no change in the ED visit rate after hours, which really begged the question, what visits are truly being avoided? And the other elephant in the room really is, what was the impact of COVID-19 throughout all of this? And those are some questions that hopefully we'll set out to answer over the next few months to a year. So in terms of next steps, we'd like to continue to collect data and to review it to see, are the trends that we're seeing sustainable, and what are the trends that will come up moving forward. We'd like to review the eMERGE visit data for the center overall and to see how as a palliative care site, we compare in terms of trends as well as absolute numbers in terms of ED visits. And we'd like to continue to understand from the patient's perspective why they're coming to the eMERGE. And I imagine that to be ever evolving. So we plan to continue to conduct patient interviews to better understand this. And so moving forward, we'd also love to hear from you as to, what next steps are possible, you think, because we're also looking to generate other change ideas to target some of the other root causes that we've identified. So that's really all I have for today. I'd like to end off by acknowledging just all the work that so many other people have put into this project. I just happen to be the person speaking today, but what you've heard is really the culmination of the efforts of all the people on the screen. And with that said, I thank you very much for your attention, and I welcome any suggestions and questions.
So Lise, thank you for that talk. That was excellent. I'm wondering, the patients that come to eMERGE, how many are directly under the care of our palliative care doctors versus a community palliative care that's been advised to come to eMERGE?
Yeah, that's a great question. So for the purposes of this project, we're only taking into consideration the patients who are actively followed at the Odette Cancer Center Palliative Care Clinics. So they have either myself when I was not on leave, or Christine, or one of the palliative care physicians in the clinic as their palliative MRP.
Thank you.
Hi, Sonal. Hi, Sonal.
Hey, Lise. Thanks for that. That was great. I just had a couple of questions. So as you know, there's kind of two separate endpoints here, the total number of ED visits, and then that, a concept of avoidable, which, as you've clearly indicated, is kind of a difficult sort of category. And we, as you know, kind of arbitrarily came up with that with some larger work as potentially a meaningful group. Do you have a split of the discharged home versus admission sort of piece? Because I think they could be two distinct groups, right? So we assume the 48 hours or less is avoidable, but perhaps not. But they could be better addressed with some of the other kind of root causes that you said, urgent care, which we do have a pilot for. And if we expand that, that might help with that group versus symptomatic concerns such as pain management that they're addressed in the emerge and then sent home. So do you have a split of that?
We do. So looking, that whole percentage is about 50%. And the patients who are directly discharged home accounts for just under 40% of that.
Okay.
Yeah. So
And then the other question I had was in your run chart, that was a nice kind of demonstration of the impact of your intervention. But I noticed some of the interventions were indicated to be introduced kind of once the mean had already dropped. So can you comment, and I'm assuming you're going to do ongoing data collection to make sure the points kind of meet all the criteria for run charts in terms of a meaningful change. Was there something else going on at the time that you think might have contributed to already a downward trend?
Yeah, no, it's a good question. So the way this chart displays, and the reason why this comes down here is if you extrapolate the previous mean, the baseline mean, so to speak, it basically goes, it changes the mean basically when it sees a signal that there's likely a significant change, which is when they see, the most number of X number of points all lying below the line. And so you're right. It's hard to believe that within the first month of introducing the clinic card, it's made such a big difference. This happened, in September. The fall of 2020 was also when kind of that second wave of COVID started hitting. So part of me can't help but to wonder how much has that contributed to it. From our clinic, in terms of personnel and human resources perspective, there hasn't been a whole lot of change, but there has been a little bit of turnover. That being said, though, the type of turnover is not so different compared to what's happened in the previous 18 months. So I don't think that's necessarily a huge contributing factor. But certainly what jumps out at me is COVID, but definitely I'm happy to hear any other suggestions, because I think that's worthwhile to explore.
Yeah, because if you look at where the point actually drops, you'd be interested to know, it's kind of small, but what happened in July and August, right? To cause that sort of, so it may have very well been COVID, but were there any other interventions implemented in the palliative patients that might have driven that down?
Yeah. There's nothing that comes to mind so far, but definitely something that I'll look into. Thank you. Jan?
Yeah, a couple things. This is great, interesting data. One, I wonder if we should go back and look at the restrictions on visitors, because most of your palliative patients were coming in with somebody, and we did tighten up the visitor restrictions for ambulatory companions a number of times during the waves. and then loosened them a little bit when we were more comfortable. So that might be something that drove it, although end of life patients tended to have like a better access, but still we could look at, I can get from the visitor portal that when we started to change things, like what the peaks were, and see if that correlates to it, because I wouldn't be surprised if that was something. And then the other thing, and we have this data, we get it on a monthly basis. All cancer patients in the province have access to an after hours and on weekends resource for supportive care through Bayshore or Care Chart. And I have the data of the phone calls and the reasons for the phone calls and the patient's names and MRNs on a monthly basis. I haven't had a lot of time. Sonal did some work with it at one point, but we continue to get it every month. If you wanted to look at it and compare it to some of your patients and just see if some of them are the same people, if it would be helpful, we can certainly share that data. So
thank you. That would be very helpful. One thing that we wanted to look at, and we did actually look at, I just didn't present it just because it didn't bring us very far, was calls into our clinic. It just, the data collection for that isn't as automated, unfortunately, as we'd like. So it was a little challenging, but that having the Bayshore after hours call data would be very helpful. Thanks, Jan. Sarah?
Thank you so much, Lise. First of all, it's amazing to see you. And second of all, this is, really great work. I'm wondering, do you happen to know, for the patients that ended up getting admitted, how many would have gone on to transfer to the palliative care unit? Is that something you, by any chance, looked at? And I guess where I'm going with that is, were there perhaps patients that maybe were ready for that transition or ended up making that transition? Yeah. And is there anything we could be doing on our end further upstream?
Yeah. No, that's a great question. And it is, I do have that data. It wasn't the focus for this, so don't quote me on the numbers, but when I looked at, because we did track the disposition, we do track the disposition even of all the patients who came to the Emerge, including those who were admitted for less than 48 hours, and the wide majority ended up going home. There were a few that either died, or there was, I think, one person who died, and then a couple who went to PCU, but that was the large minority. It was not a big trend. Yeah, but I can look at the data again and get you the absolute numbers for sure. See something in the chat. I'm just going to bring it up. Great.
Yeah, I think Sonal's saying that you can also look at the urgent care data. And I think that's like a perfect marriage, right? Between what you've just done and what Sonal's doing. Yeah.
Sure. And Sonal, I apologize that I haven't actually connected with you yet. I've been meaning to connect with you about this urgent care clinic, but just with everything else going on.
Ditto.
I think proactively, we should do this because we now have been given space on C ground. We're still not ready yet, but we're getting there. We're just trying to hire staff right now, but it would be good to bring you guys to the table to make sure that the data collection includes everything so that we don't have to go back retrospectively and search for this information. We should likely bring you to the table and have a conversation about what we should be collecting.
Yeah, absolutely. I was just going to say that, Jen, Lisa is going to reach out to you and, the other tables that we both sit at in terms of those larger initiatives for palliative patients. And we are collecting what percentage of patients are palliative coming through urgent care. And the reasons that they're like, we have very detailed level, everything from what interventions they had for pain, effusions, and what percentage get admitted or not. So this is a really nice kind of, and we're thinking of actually expanding it to a dashboard on Power BI. So we have high level metrics that will be captured, especially when we expand to C ground. Okay. So it'll be visible and reportable. So we'll connect.
Amazing. Yeah, I'll send you an email and we can connect. Thank you for that.
It's also a space that you guys could potentially consult in as well.
Right. Yeah, exactly.
So Lise, I was interested that one of the issues was language barrier. Can you specify what you meant by language barrier and
Yeah.
what you might be able to do to help?
So really what I meant is patients whose first language is in English or who aren't fluent in English. And so that was one of the main one key identified potential cause for having difficulty with accessing care because of the lack of understanding of English. And I know we have language lines, and I think, you know, the ideal of how we go about caring for patients who have a language barrier versus the reality in terms of, you know, even availability of the machines and the added layer of virtual telephone visits now in COVID makes it harder. And I suspect that the percentage that the language barrier issue is a bigger issue than I have found, because what I've documented really is just the percentage that's where there's an actively documented language barrier in the notes. And I suspect that the real percentage is likely much higher than that. In terms of, you know, how to solve that or address this issue, I think that's a great question and something that we've been thinking about. But I haven't found a good, you know, it depends on practice behavioral change, and I think it's hard to affect that.
Thank you.
Thanks, Yi. Oh, Sean and then Sarah.
Just in regards to the language barrier that you just brought up, I was just wondering if, and maybe Jan or Dawn could answer this question, if there is a way for us to be able to document, like I know we collect that information with new patients, their preferred language, but it would end up in Sovera, not readily accessible, but would there be a way to flag their preferred language in SunnyCare or Mosaic so that, because I think that would also facilitate with telephone calls when we're working, if you can just look at SunnyCare and see, oh, this patient needs a Mandarin interpreter or needs a Russian interpreter or whatever.
So it is in the registration section, because I look people up all the time before I call them. And I always look to see what language they speak. How accurate it is another conversation, because I often find myself not having booked somebody and find out I need somebody, but it is there. But you know what, we could talk about, maybe there's a way to get a flag similar to the smoking cessation flag or something like that, that would actually link to language. So let me send that over and see if there is some way that we could do that so it's more visible.
Or is there any way, Jan, where if it's in my chart, like can patients put their preference in my chart and it can flow through? Is that already in existence?
What patients put in my chart doesn't flow through. What we put in my chart flows through to them. But let me ask and just see. I wouldn't be surprised if there's a way to put a flag on the system. But as I say, it is requested as part of the new patient assessment and referral. And the staff do put it in to the demographics section. It's on the front page of the demographics if they know about it. But it is hit and miss. And as I say, I readily attest to it because I often phone people and I often get caught. So
Jan, I think with CPOE coming in with all of the upgrades that is happening to SunnyCare, you're going to see the tool become a lot more robust in terms of the information that we're collecting from patients and what's being shared. And to answer Dr. Tarabi's question, no, unfortunately, what's put into my chart, we're populating my chart, so to speak. It doesn't go the other way around. But, you know, we've had so many bump outs with CPOE. Hopefully we'll start to see a bit more robust information from that.
but we'll ask and make sure it's highlighted and see if we can figure out how to do that. Sean, you still have your hand up. Do you have another question?
Sorry, no other question, just bad Zoom manners.
All good.
We're coming out of Kano. It's probably still up for Kano.
That was 2 hands up. It was amazing conference. Everybody's gonna get a lot of pestering from me now because I'm like primed for this. And I saw this talk coming up and I missed the talk, but I probably like, oh my God, I'm just like so many issues. You have to do something.
Actually, one question I did have, sorry, I didn't put my hand up.
Okay.
One of the questions I had was related to Dr. Gandhi. You had mentioned getting the metrics and the data into Power BI. I think this would be very useful for nursing in terms of what is it that we're seeing patients for in the Seaground clinic. I think that would help to generate some good conversation and some professional development from Erica and Taryn as they're, so come the new year, we're going to be rolling out some professional development sessions around palliative care to our sites and as a supportive site. And I think that data would be very helpful in terms of that professional development. So if you're willing to share that data with us, it'll help to really make that information, it's my favorite word today, more robust.
Sure.
So Lise, I noticed that you put in increased MD video visits as one of the interventions, and with COVID and everything, we've been doing that a lot. But what do you see as the limitations and of this type of visit for now for assessment?
Yeah, I think I should have been a bit more, I should have explained it a little bit more. So the rationale behind trying to increase MD video visits is, so the actual intervention is try to increase the video visits in lieu of telephone visits. And that's because when interviewed, both providers as well as patients felt spoke about the value in having the visual. So I think it wasn't meant to replace in-person visits, but meant to increase in proportion to telephone visits. So as a proportion of the overall virtual visits. And so that's what we attempted to do by really discussing as a team and encouraging the use of video over phone. There are so many potential limitations, and that's probably why this never took off. It did start to increase in terms of the percentage of video calls, but in a very slow way. And I think it's because whenever you're dependent on technology, and especially when both sides are dependent on technology, that can take time to take. And I've been in contact with, I think one good example of people who have done it well is the Emerge, who have kind of piloted this whole virtual Emerge. So I've been in contact with kind of their lead who did that. They had this whole troubleshooting guideline that they sent to patients, but ultimately I think it is a lot easier and more convenient, particularly when you're pressed for time, to pick up the phone than to try to log on to a video platform and troubleshoot, not having enough bandwidth and having the lag time are just kind of, I think, some of the technical difficulties with that method.
And do you find, like most of these patients, is it family that you're dealing with by video? Because I find my lung patients, a lot of them are not very tech savvy, and they don't know how to do the visit.
Yeah. So I will say, full disclosure, that I have not done a lot of video visits because for much of this time I was actually on mat leave. So this is what I've heard from my colleagues. But yes, but from the relatively limited amount of video visits that I myself have done, there's always a family member there, and it's always the family member that directs the call. And most of the time, the patient is there. Sometimes they're in the background, sometimes they're sleeping. it varies. Yeah.
Great, thank you.
Hey, Dawn.
I just wanted to add in, Lise, I think you were aware just before you went on mat leave that nursing does have the capability of Zoom with patients as well. So that platform is available. The training was provided to Erica and Taryn to be able to video assess patients, as well as bring other clinicians and key stakeholders into the assessment with the patients. So I just want to throw it out there that we do have a private space that was allocated, and the platform was set up so that if there's any physicians that are on this or watching this presentation today, if you were not aware, that is aware through nursing. Okay.
Thanks for that, Dawn. So I know we're a little ahead of time, but are there any other thoughts or comments or questions? If not, I wish you all a good rest of your lunch hour. And I just wanted to say thank you again for your attention and for coming here.